Thank you everybody for coming. Just a little bit about my background. So this is my 25th year, sorry, my 20th year in the healthcare technology management. I started out as an Army biomed in 2005, and I've held just about every role from BMET 1 all the way through regional operations director. Worked for in-house programs as well as outsourced programs. Worked with plenty of third-party programs as well. And I joined PartsSource about a year and a half ago. It's good work for me. Yeah, it's fine. Okay. So to level set a little bit, the presentation is based off of a survey that we did a bunch of healthcare technology managers across the country. So hundreds of healthcare technology managers filled out these surveys, and we developed the State of Healthcare Technology Management Insights report. So in this, we're only going to cover a couple of the topics within that report. I have a QR code at the end of the presentation. You can download the entire report, or if you want to stop by and see us at booth 402, we have a hard copy there if you'd like to take a look at that. What this is not a PartsSource commercial. This is not anti-OEM, this is not anti-aftermarket, this is not pro anything except for data. So the entire point of what I want to talk to you about today is looking at the data and making data-driven decisions to help, again, decrease your costs, increase your efficiency. So I think we can agree on a lot of the topics on the left-hand side. Data is driving the future of healthcare. There's no doubt about it. Everything that comes into the hospital is giving some sort of data. Every patient monitor, every piece of equipment is putting something back into electronic medical records, or it's storing data locally, or you are recording data from your maintenance on those devices and putting that in your CMMS or any of your other, your ERP or anything like that. So data is definitely driving the future of healthcare. Another thing, expenses. Expenses are rising faster than we can believe. We have a lot of uncertainty in the economy. Not going to talk about tariffs today. I know that's a very controversial topic, but it is something, it's a reality in the healthcare space. It's a reality everywhere, but expenses are rising a lot faster than revenue. Margins are thinning for hospitals. I think we all see that in our jobs and our everyday work. We're always being asked to do more with less. And I think the only way to do that is shift to data-driven decision-making. And the outcomes are just going to be much better for our departments as a result. So just a few facts and figures. 66% of hospitals expect supply costs to grow. That number was from last year. I bet that number is a lot higher this year with everything going on in the economy. They expect a 15% reduction in their operating margin. Biomed's a cost center in the hospitals, not a profit center. We're the ones being squeezed for a lot of that reduction. 20% spike in labor costs. So not only were we being asked to reduce our budgets, do more with less, now we have less money to hire the people to do that work as well. And 50% of hospitals expect capital spending to be flat. That means the equipment that's old, that we want to get replaced, that's aging out of the inventory, we're gonna have to keep that running for a lot longer. It's just the reality of the situation we're in right now. So why data? Why using data to drive decisions? Why is that so important? So I think data is really important because it relies on facts, not feelings. I think we need to be, we need to have feelings in our everyday work, but looking at the decisions we make about what equipment to buy, what parts to buy, where to buy those parts from. We need to look at the data to make those proper decisions. Your leadership decision, making that decision based off data, you appear fair and unbiased. You're looking at the data is telling you what that solution is, and you're making a decision off that data. So somebody can't say, oh, well, you like that person better, or hey, that vendor came in and took us out to lunch, so you went with them instead of this one. You could have saved costs. I think that the most important decisions are going to come from data, but it has to be available in real time and aligned with your goals. Those are two very important aspects of the data. If you're looking at 6-month-old data, it's only going to tell you so much about what you did, but it's not going to help you with today's decisions on what you should do moving forward. And then, just to be realistic, not every decision that you make is going to be based on data, but I think the most impactful ones are going to be. So it would not be a good conversation about data if we didn't talk about data accuracy first. I think, I guess, show of hands in the room, anybody that's experienced bad data in their CMS. Everybody's hands. Everybody that's been in a CMS should raise their hands because there's no CMS that's perfect. There's always bad data from one thing or another. It could be poor data entry. It could be poor data governance, poor access control of the system. So people that shouldn't be doing things are doing things they're not properly trained on. So to start, you really have to have good data governance. Having a set of policies and procedures that really help manage your data. You have a master classification table for your models of equipment. Things along those lines. You need to make sure that you're all speaking the same language. Because if you make those decisions based on inaccurate or incomplete data, I think we've all been in that boat as well, where you assume something based off the data you have, but the data wasn't accurate and led you down a path that just, it wasn't the proper path. It could have been any number of things. You could have wasted money. You could have wasted time. A lot of different things can happen when you rely on bad data. So everything that I'm going to talk about today is based on the assumption that we have good data going. Therefore, we have good assumptions coming out. So from that survey that I mentioned earlier, these are some of the goals that the HCM leaders developed as their primary goals for 2024. Top of the list, bringing equipment repairs in-house. I don't care if you're an outsourced program, you're an ISO, you're a third party, whatever you are, you're trying to save costs by having the hands that you pay to be in your building do those repairs. I think that's the nature of just what we want to do. If you can get those parts for a decent cost, you can get that training for your technicians to do it. It's going to increase your uptime and it's going to decrease your cost. I don't think anybody can argue with that fact. If you do it with your own hands, it's a little less expensive. Standardizing processes and procedures to increase efficiency. I think this is the thing that's often overlooked, is the processes can be a lot of waste of time. Are you looking at how long it takes for your technicians to order parts? How long does the approval process take? You have a great finance process, so your POs are quick. There's a lot of factors in this that can slow down the process. So by increasing your efficiency through those processes, you're able to do just a little bit more with less. If you focus on all those, it adds up over time. A lot of you in-house teams, you're having to demonstrate your value more and more. You're having to diversify a lot, probably do things that aren't part of a traditional biomedical engineering department to show the value of your in-house team. Because a lot of outsourced programs come in and want to save costs. So they say, we're going to save you 20% up front. To maintain your competitiveness, you're having to do other things. Reduce operating costs. I think that's something we're all being asked to do. As I mentioned, margins are thinning, reimbursements are down. So your operating costs are going to go down. So you're going to have to find alternative methods to get those repairs done, like bringing those repairs in-house, looking at alternative vendors for some of your parts instead of going with OEM, maybe looking at aftermarket. We're going to talk about that a bit more. New CMMS. Is anybody going through a CMMS conversion right now? You raised your hand last time. I don't know if we can use you again. Well, what are you converting to again? AIMS 3, okay. So you're going through, can I ask you why you decided to convert? And I'm sure that was causing your technicians a lot of wasted time, probably frustration from management. You couldn't provide reporting back to your leadership, all those things. Yeah, exactly. So that's a great point of how you're going to reduce some of your costs, increase your efficiency, and go with a new system. Taking ownership of capital planning. Who's involved in capital planning here? Anybody in their shops? Only a couple. Okay. So I think having Biomed involved in all capital planning is a key aspect in saving costs, because you're the one that can provide all the data about the operability of that equipment. You're the one that can work with your vendors to find out, are the parts still available? The equipment could be in great shape, but if there's no parts out on the market to maintain it, the second that thing dies, you're out of luck. So being involved in that capital planning process continuously from the beginning is very important. You can also embed things into that capital planning. Training. Sometimes you can negotiate training right up front. You can negotiate different types of contract costs. If you don't have the right training, maybe you're like, hey, we need a year contract to cover this while we get trained up. So being involved at the front end is extremely important for your efficiency. Integrating with another health system. Is there anybody that is merging with another health system, or maybe they're merging with another biomed company? So like there was an acquisition 2 years ago where TriMedics purchased Airmark. Okay, so that's another thing that we're seeing is there's value in scale. So the bigger you are, often the better negotiating power you have. So we're seeing a lot of different health systems or different types of companies merge to get that scale so they can be more efficient. And then last thing, we're going to talk a little bit more about this in the next slides, is taking ownership of service contracts. There's really two models of service contracts. One is the centralized. Biomed owns everything. Biomed has the budget for everything. Biomed manages everything. I think that's the best service model. Then there's the decentralized model, where some department leaders hold their contracts. Maybe radiology holds a few, cardiology holds a few, nursing owns a patient monitoring contract, something like that. In that decentralized model, there could be a lot of duplicative coverages. You could be, if you're an outsourced program, you could be paying your outsourced company to maintain that. While you have a service contract, you're paying on this side as well. So having Biomed involved in all the service contracts, they might not need to own them in their budget, but they need to have visibility of all of those so you're not getting duplicate coverages. That's another thing where you can reduce some costs by having a global view of that. All right, so some key findings and opportunities. Just take a second to absorb these. The forces converging on HTM are many. A lot of market forces converging on HTM. A lot of things going on. A lot of pressure on leaders, as we mentioned, to hold down costs, keep budgets down. And then nothing is possible without credible, verifiable, accurate, and timely data. As I mentioned, timely, it has to be current data. If you're looking at old data, you're making old decisions. So here's the opportunities that we came up with based on our survey. I mentioned inflammatory impacts and things like that. We're not going to talk about that tonight, but it is in the full paper. Today, we're going to talk about opportunity two, optimizing cost and quality with parts. We're going to focus mainly on that. And we're going to spend some time on five, looking at complexity and cost and equipment service. But as mentioned, these other opportunities are discussed in detail in that paper, and I encourage you to download it or stop by and take a look. It's a lot of great information there. So opportunity two, looking at cost and quality in parts. Whoops, sorry about that. All right, one of the things we're going to focus on here, quality return rates. So the reason we focus on quality return rates and not overall return rates is because quality is something that's kind of out of your control. The rest of the return rates, whether you maybe you ordered a hero kit, you ordered 5 parts and 4 of them got returned, that's part of your overall return rate. But if there's DOAs and things like that, we focus on quality return rates so that when we're making a decision about what parts to buy from who, we can look at those quality rates by vendor and say, well, this vendor's got great quality rates and aftermarket parts at a discounted cost. That might be the best decision at that point. And it's just really helpful to understand the differences between OEM and aftermarket parts when it comes to those return rates. In the next couple of slides, maybe it's the next one, we'll talk about those return rates in detail. So I think we've all been in a situation where, it's Friday night, maybe it's 4 o'clock, you get that phone call from the radiology director, emergency room CT is down. I need somebody here now. I don't care what it costs to get them in the store, you get them here immediately. We need it up and running. And often our first call is to the OEM because we know they have field service techs in the area. We know we're going to give them a PO and they're going to show up. We're going to pay that premium, they're going to get there. Often it's just based off of assumptions and urgency. It's not based off of that quality decision where you're looking at the real value here. Is it the right decision? It may be. It may be the perfect decision for your facility, but it might not be. So I think the past state has been it's been characterized by clinician preference. I know we've all had doctors that say, I want this thing, and this is the thing I want, and I don't care what anybody else says. It's not about the features. Sometimes they know somebody, sometimes they like some of the bells and whistles. They might even be using it for the study that it does, but they really like that piece of equipment. We've had some influence from OEMs. I think this is, you have influence from aftermarket as well, but influence from OEMs is a big thing. They say you need to buy our stuff because you have all our other stuff. You need to buy more of our stuff because you have one type of thing. So a lot of pressure from different outside sources. Now, I think instead you can really make a more cost-effective decision looking at the data without losing sense of urgency. So is there options like forward stock? Can you have some of those more critical parts on hand to mitigate those situations so you're not paying that premium to have somebody walk through the door Friday night? Really, it's the key elements for data, as I mentioned, quality return rates of OEM replacement parts, quality return rates of compatible replacement parts, and then the potential savings. And those 3 factors can help you make a informed decision about where to go. So like in theory, if a quality return rate is about the same or better, and the parts cost less, that's something to look at, see where there's an opportunity. Does anybody in here currently track their quality return rates themselves in their CMMS? Does anybody have that? About a third of them. You've got just your top third vendors or something like that? Okay, and do you track all your aftermarket as well? Perfect, yeah. Right, now that's a great point. I mean, yeah, would you use a case part that's from aftermarket? Probably, but would you use the batteries in a defib? Maybe not. Maybe it depends on your facility. But yeah, I think it's a good point. Which devices would I use aftermarket or compatible parts, and which would I not? And just have that matrix. I think that's a great point. So this is looking at quality return rates for OEM and aftermarket, both imaging and biomed. So on the left, you'll see that it's a 0.3% difference in quality return rates, just between the new aftermarket and the new OEM. Now it's a little bit of a bump, but it's really only a 1.5% delta between the OEM part and a refurbished part. So as I mentioned, looking at modality, looking at location, looking at a lot of these other factors, and then looking at this as well, can you take that 1.5% risk? Can you take that 0.3% risk to save some money? The decision you have to make, depending on the modality, depending on the location, depending on the model, yeah. Correct. Correct. Yeah. Anything that's from an aftermarket provider, a non-OEM provider. Yeah. Jump over to imaging. That's a 0.7% delta between aftermarket and OEM. A little bit of a bigger delta over to the refurbished, but again, it's a decision point where you say, hey, is this thing end of life? Is it at a clinic it's only used once or twice a week? What is the criticality of uptime for this device? It's different from that one in the emergency department where you got that 4 o'clock phone call on Friday. It's one where it might go down. They might call you 3 or 4 days later, like, hey, it stopped working last week. Can you send somebody over? Do you need to dispatch the OEM immediately to be there that night? Yeah, probably not. But I've seen it happen. Next, we're looking at the savings based off of these different modalities. So as I mentioned, that just let's look at anesthesia, for instance. That can be a controversial one. It's approximately a 48% savings from OEM to aftermarket. Is that worth it? For 0.3% quality, is it worth it? No wrong answer. Anybody? You're saying no. It is. It's a huge liability. It can be. It can be, but it doesn't have to be. What if you buy your buttons and your other ancillary pieces that are not critical, if you will, as part of the machine? You could buy some of those things aftermarket, but buy the critical components from the OEM. But still looking at those return rates, you got to make that decision. Is it the right one for anesthesia? I would say for patient monitoring over on the left, 57%, I'm all over that all day long. 57% for 0.3% in quality, I'll take that 57% savings to the bank. Sterilization, probably not yet. It does. Right, exactly. And your point about having that matrix that says, well, maybe I'll buy maybe let's just say there's 20 parts available for one piece of equipment. I know that's really low, but I'll buy these 10, I'll do aftermarket, but these 10 I want OEM only. Having that grid and knowing ahead of time is going to save the technician's time when it gets to that point. In the imaging space, you can see there's a ton of savings. The ones in dark blue, those are the imaging space. There's a ton of savings. Mammography. Mammography is a great one where you can make a big amount of savings, a big impact to your overall budget. Do you want to do it with CT? Maybe. Again, it goes to the criticality of the equipment. So you have the return rates, you have the savings. Now you're looking at the modality level, you're looking at the location, all these other factors that play into that. We also talked about we asked them, the managers that we surveyed, what are your priorities? Reliability is number one. But I would argue to say that the top 7 are pretty much the same priority. So everybody wants everything. They want it reliable, and they want it cheap, and they want it good. There's this triangle. It's usually used in food service a lot. You can have it fast, you can have it cheap, or you can have it good. You can only pick 2. I think you can get all 3. If you look at the data, you can make decisions. You can get it fast, you can get it good, and you can get it less expensive. I won't say cheap. Cheap can have a negative connotation, but you can save money and still maintain quality and speed. All right, so insights and action from this section. First, look at the overall budget impact at the site and modality level. So it's an important factor, not just looking at a CT is a CT is a CT. They're different depending on where they go. A C-arm is not a C-arm, it's not a C-arm. It just depends on where you're using these, what that criticality is. When the quality return rate for an OEM is lower than compatible, consider a threshold for those savings. So you don't have to evaluate every single purchase. You don't have to evaluate everything all the time. Evaluate things at one point and say, if we're going to save over 10, 15%, whatever, that 1% threshold in quality, let's do it. 1% threshold, and then you put a savings, 1% in the quality, and then you put a savings threshold as well. This is a good decision, and you just let that go. That could be with your procurement team, that could be with your technicians, it could be anybody. But having that decision at that point is going to save you time. Again, factor in the part criticality, the need for redundancy. Do you have a ton of these? You need to overnight that pallet of batteries. Seen that happen as well. Somebody needed 1 battery. They're like, well, we need more. Let's just order 20 of them, 30 of them, 40 of them. I'm going to overnight it because I need the 1. They overnighted 39 extra batteries on a pallet. Might not be the best decision. All right, a couple more. So for imaging equipment, consider several criteria. We already went over this, so I'm not going to bore you with reading it. Just take a look. Important factors to look at when you're thinking about your imaging equipment parts. Anything missing on this, you think? End of life? Do I need to invest in a brand new tube or a brand new whatever? Can I limp it along with refurb? What's the criticality there? Location, is it critical? Are there redundancies, backup equipment? So again, 15%, that's what we're saying. If the savings, 15%, so 1% on quality, 15% savings, that's just a recommended threshold, but you're gonna make those decisions based off of your install base, based off of your purchasing, based off of your risk profile. Are you risk averse or are you comfortable with taking a little bit more risk? Greatly gonna depend on, again, going back to location, where is the equipment? What's the criticality? All those factors are gonna play into it. All right, talk about service contracts a little bit. Service contracts are probably one of the most complex things in our industry because every single hospital, sometimes different departments within the same hospital, are getting bids from people all over the place. And often there lacks a lot of continuity in those contracts. There's a different process. So we feel that there's been a kind of a lack of insight. Providers are not using benchmark data and things like that. So the recommendation is use benchmark data, reduce variations in contract. You can reduce costs by doing this. You've seen a couple of slides that we had one that had over 465 unique contracts, I believe, for the same exact asset. We'll talk about that in a second, but across 100,000 service contracts, there was variation of, some of the contracts cost more than double what the other ones cost for the exact same entitlements. So that lack of standardization, it can be a drag on the system. Complexity, variance, and lack of transparency. This is why it's important to have it centralized. If you have the same people looking at the same contracts all the time, they're going to be able to look at those and say, oh, I just did a contract a month ago, or we have a database of contracts. I can input all this stuff in and we can compare it to the last contract that you did. If you have individual clinics or individual departments doing their contracts, you're going to see variation because different people, different priorities. And given the fact that contracts often take up more than 50% of the budget of our departments, I mean, that's a huge nut to go after. I mean, that's above staffing, that's above parts cost, your other parts costs. 50% of your budget goes to contracts. Really needs to be a focus moving forward. What can you do to get those things off a contract, get those in-house, do those repairs with your own hand? All right, so there's a move towards standardizing contracts powered by data, identifying reducing variances, identify variable alternatives. There's options for your service contract. You don't have to go with the OEM. You don't have to go with all the same provider. You can shop around. You can compare that with your peers. You can, I mean, we're meeting hundreds of people here. Share people's cards, get in touch with each other, talk about these things. The more we talk about all this openly, the more transparency we're going to see in service contracts. So as I mentioned, the analysis that we did, we collected contracts, 100,000 individual service contracts, more than 500,000 service events is what went into this. And that's just scraping the surface. I mean, there's a lot more than this. Service contracts are worth billions of dollars in this country. If you look at just 50% of all of our budgets across the country, that's quite a bit. So we found that regardless of hospital size, 140 for under 1,000 beds was the average number of contracts, 156 for over 1,000 beds. That's not that big of a difference for those size facilities. So a lot of contracts. But what we found is that most of the contract, low value, low risk equipment. People were just hitting an easy button and putting things under contract. It could have been an auto renewing contract, been in place, you may have inherited it. But we found there was a ton of opportunity in those under $50,000 contracts that are applied to non-critical assets. All right. So we did a time and motion study as well with those contracts and looked at how long is it taking these facilities to process these contracts. You notice that it's about the same time to complete regardless of contract value. I personally would want my team spending more time on the high dollar contracts and maybe putting some things in place, a matrix, maybe some standards of different things in place that you could say, okay, here's our standard terms and conditions. We don't need to spend as much time on these low dollar contracts, these low value contracts. But average of 108 days process a contract, or 3 months just to get a contract in place. So this is taking a ton of time, up to 4 months overall, regardless of price. This doesn't make sense. This is what I was talking about. Oh, 519, I was way off. 519. 519 unique service contracts for the exact same model, ranging from 7,900 at the low end to 18,600 at the top. Exact same entitlements. We took 100,000 service contracts in, 519 for the exact same model, exact same entitlements, some double the price. This is exactly why it's important to bring those into one central place, because I don't have the data showing whether it was one health system that had both of those extremes, but it's quite possible. The same health could be, depending on where they bought it, they could have got some discounts at purchasing, things along those lines. But that huge variation, that's just too much. Does anybody in here have a centralized view of all your service contracts? You do now? Perfect. You do now. No, that's great. I mean, it's you got to take steps to get there. It doesn't happen overnight. Yeah, I think with more volume, you can get deeper discounts. So there could be some good reasons for variability. Thanks for pointing that out. Could be some good reasons for variability, but should you pay different prices within the same health system? Or should you say, hey, let's level this out so we're paying the same on all the same pieces of equipment, and you can win some here, you lose a little here, it averages out in the middle. Let's work together. You got to partner with your contract provider. It should be a partnership. It shouldn't be transactional. You should have a good relationship. Talk about what your needs are, what your strategic goals are. That should be part of your contract management policy. All right. So this is looking at total contract years. So in all that information that we pulled in, we had a model that total 463 contract years or coverage years. For those that don't understand the math behind that, it's if you have 100 contracts, each with 5 years on that contract, you have 500 years of coverage years. Just how the math works out. So you're looking at full service. This is another thing you can do to save costs. If you're not tracking your T&M spend and comparing that with your contract spend, you're missing out. So you say, what would, even if it's covered under the contract, looking at what it would cost you outside of the contract versus the contract, where are the opportunities to reduce some costs? On the bottom line here, for 16% savings, which is less than about $1,000, I'm probably not going to take the risk for $1,000, depending on what the asset is. If somebody else wants 59% savings, I might be like, it makes sense. With that 59% savings, I could train somebody. I could train 2 people maybe. Then we're also increasing our efficiency. We're showing the value of our department to the rest of the hospital. We're decreasing downtime. So there's a lot of other factors in here more than just cost. Also knowing your number of corrective events in comparison to that as well, because that's going to greatly factor in. If you have high correctives, that thing's breaking all the time, keep that contract in place and cap your risk, move on with your day. But low, 1.13 service corrective events, 1.75. They seem like reasonable things to take risk on, right? Okay. So insights for this one. Consolidate and rationalize contracts with evidence-based insights. Consolidate. That's the number one thing you can do right away. Consolidate those service contracts into one spot so you have global visibility of where you're spending the money. And after that, you can rationalize those contracts. You can maybe you can consolidate some of those contracts into one contract, save money that way as well. Create a data-driven transition plan to bring those low-dollar ones in-house. Look at the total cost of that contract. Look at the total cost it would cost you outside of the contract. How much is it going to cost for training? What does that give you? What's that ROI? Do you still have high parts costs even though you get training? What's the PM kits cost? So looking at overall total cost of ownership, looking at the cost it is under the contract, and then creating those transition plans, presenting those transition plans to leadership, saying, hey, I got to spend this much now, but we're going to save this much in the first 6 months, this much in the next 6 months, and then this much every year thereafter. Putting that in front of administrators, that's something people can understand. Keep it simple. And then as we talked about, using the evidence-based outcome data to lower those contract costs. So while they're consolidated, you can look across the spectrum and say, okay, we're paying more over here, less over here, going back to your vendors and negotiating those contracts. You saw there was as much as 60% savings on some of those. Okay. Measuring asset level service costs and performance. So that's another piece, is having a contract in place doesn't mean everything's up all the time. You got to measure the performance of your contractors as well, making sure that they are performing within the KPIs within your contract. Because if they're not, then what's the point of having a contract? We put a contract in place to avoid risk with money and increase uptime. Those are the 2 driving factors of contract. If we're not increasing that uptime, are we really saving money, or are we losing money because the equipment's down and we're not able to use in procedures? So tracking that at the asset level is important. And then I'd say it again, leveraging the national benchmarking data. If you don't have access within your health system to national data, there's plenty of partners out there that do have access to a bigger data set that you can compare your information with to make better decisions. Usually, not always, but usually more data is better. It's just going to give you a broader stroke to look at. Okay, so recapping on opportunity 2. Look at the overall budget impact at the site modality level and consider the quality return rates and pricing differential thresholds. A couple of easy things you can take back. If you don't have access to the data, that's a problem. But you can start now. It's not too late to start capturing the data so you can make these decisions. Work with your vendor partners. If you have a procurement group you work with them to see if they have access to this data. You don't have to recreate this wheel. The data's somewhere. You got to figure out where it is and collect it and then start looking at that. So with service contracts, consolidate, consolidate, consolidate. Have I said it enough? I think consolidate is the key here. And then create a data-driven transition plan. Look at those cost of ownerships, look at the training costs, look at all of that and see how you can transition some of that in-house, save some costs, increase your uptime, increase your efficiency, and then use the evidence-based data to help lower some of those contract costs by centralizing and looking at those in a holistic format. Yeah, and I think you bring up several great points. Training. Yeah, training is a huge thing. Do you have hands on your team that can do the work or that are capable of doing the work with the proper training? Everybody's facing trouble hiring. I was talking to somebody who's here locally. I think they have like 14 positions open. No, that was Cleveland. It was up in Cleveland. They have about 14 positions open, 14 technician positions open. Like, that's 3 or 4 times the size of some shops, and they have 14 open. So everybody's struggling with trying to find the right people. I think we're all trying to find unique ways to continue to train up our teams. We're hiring people that have electrical engineering background that don't have biomed. We can train them on a little bit of biomed stuff. Maybe they have mechanical background. They're great with their hands. Okay, I can train them on the customer service and healthcare stuff. They know how to repair things. So we're all looking for alternative ways to try and train people up to that point. Yeah, you're right. You got to have the training, or you do have to rely on a contract in some cases. But having that comparison, being able to say, hey, this is the path to self-sufficiency by training, whatever it may be. That's a key aspect. Yeah, you make a great point, because again, if it's not centralized, then sometimes your technicians might not have view of the contract. They want the equipment to get up and running. They're picking up the phone, calling people, they're trying to get it repaired. And if they don't know a contract, you could be spending money for a contract and spending money to maintain it at the same time. So having that data directly available to your technicians, so that when they pull up that asset, it flags and says, hey, there's a contract, here's the coverages, and they can evaluate, oh, what happened is outside of that, or hey, that's right inside this, let's make a phone call and we're back up and running. Thank you. Yeah, and that grind of going back to the table over and over again, if you didn't have all the data to back you up to have those conversations, if you were just like, I think we'll save money, I just want to do it myself, and that was your stance, probably not getting too far with that. But having all the information, sitting down and saying, this makes sense. You know, you can help us, we can help you, we're going to keep your equipment. If you won't want to train us, when it's time for a replacement, I'll buy something else. And I know that's a lever a lot of us have pulled. It's like, hey, look, if we can't get training on this equipment, if we can't help keep this equipment running for the hospital, why would we want to have that in the facility? We want stuff that we can maintain ourselves, that we can keep running. We don't want to have to rely. We need to rely on the OEMs and other vendors sometimes. We don't want to have to all the time. Thanks for sharing that. Those over here is talking about having access to the warranty data as well. So being able to pre-plan that potential contract need and looking at how many correctives were needed during that warranty period and whether or not they even go with the contract. Another important piece. Okay, so the conclusion. You know, I feel that embracing the future of data for improved outcomes. Data is essential for healthcare organizations to respond effectively to the new reality. It's unavoidable. Data is what we need to do the jobs that we need to do. I'm going to spare you reading this. Go and take a look. So on the left-hand side here is the past state. It's kind of how things used to be, or it could still currently be this way for you. On the right side, that's where we want to be. Standardization. Criticality determines risk tolerance. On that right side, that's where we want to be. If we were in all of those, that is a pretty good biomed shop at that point in time. All right, data, there, we have it. It's being collected all the time. Evidence, I just showed you plenty of evidence, relatively compared to the industry, a smaller data set, but 100,000 service contracts. Pretty good size. The evidence is there. We have the technology. We have technology everywhere. Everybody's doing computer-based documentation of everything. So the technology is there to support the data. Time, leave the status quo behind and embrace the data. I have a couple scorecards just to show you how we track some of the quality return rates on our end. I know this is an eye chart, you can't see a lot about it, but what I wanted to highlight is that we're looking at the quality return rate. We're looking at the quality return rate over time, quality return reason. So it's not just any quality reason. Is it, did the part arrive damaged? Was it a shipping situation? Was it a DOA part? Was it a warranty failure? So we're looking at all those different reasons for the quality return rate going up and seeing when it drops below a threshold, we work with our vendors and say, hey, we're noticing the quality is starting to slip. We need you to improve your quality. What can we do to help? You know, where can we come to the table to help you improve that quality? And if they slip, we remove them as a vendor and give them an opportunity to improve. But we'll say, okay, while you're doing that, we're going to remove you as a vendor. And then when you get better and you can prove it through your quality management system, then we'll let you back onto the platform and we'll continue selling your parts. But we track it at a very granular level to make sure we're looking at all different aspects. This is just one more. So it's showing process returns. As I mentioned, not all returns are bad. If you look and you have a 50% return rate somewhere, is that bad? We don't have enough information to tell if that's bad. What if you bought 2 things and you didn't like one and just sent it back? I probably return 10%, 20% of the things I buy off Amazon. It's free returns. I just drop it off and they ship it back. You know, it's an easy button. But does that mean it's Amazon's fault? Is it a quality issue with Amazon? Sometimes, not always. All right, this is a QR code to the report if you'd like. We also have it at the booth. This includes all of the information I covered here today, as well as the rest of the key findings and opportunities in that report. I encourage you to download this, take a look, stop by our booth 402, ask any questions. We're going to be around. Happy to have a discussion. And just make sure that if you didn't scan your badge on the way in, if you wouldn't mind scanning your badge so that we know who attended. I greatly appreciate it. That's all I got. Thank you. Oh, yeah.